Thank you very much, Dick. I'm delighted to be back at this meeting to share with you some interesting, I think, developments in an important aspect of myeloproliferative disorders, how to prevent thrombosis and bleeding in these diseases. And the catchword, I think, for this is simplicity. And you'll see as I go along what I mean. I'm sorry, but here. Okay. So let's begin by saying, what is the difference between normal hemostasis and thrombosis? All of us are big containers for blood that is being pumped around in a series of intact tubes. And if the pump fails or if the tubes are leaky or obstructed, we have significant consequences. And this is what we're going to try to explore. Hemostasis is limited blood clotting that maintains normal blood flow and prevents the blood from leaking out of vessels if they're injured. On the other hand, thrombosis is dysregulated, usually excessive clotting that leads to obstructions in the normal circulation. Now, normal hemostasis is a balance. On the one hand, there is injury to blood, if there is injury to blood vessels, the process of blood clotting is very localized just to the site of injury. And once small blood clots form, they are disposed of by fibrinolysis, a process of natural resolution of blood clots, so that the circulation remains in balance. And this, therefore, maintains the vascular integrity, the intactness of the vessels, and the normal blood flow on which we all depend for conscious activities, despite continual minor injuries or repairs. Now, thrombosis and bleeding are both very common in the myeloproliferative diseases. They're most frequent probably in polycythemia, a bit less so in essential thrombocythemia, and a little less so in myelofibrosis. And these abnormal processes relate both to abnormal numbers of blood cells and abnormal function of the blood cells, as we will see. And these two types of abnormality are major contributions to mortality, to morbidity, and hopefully not to mortality during the course of the disease. Both large vessels and small vessels are affected. In fact, clotting in the veins within the abdomen is so commonly associated with myeloproliferative disease that if it occurs in an adult, that's one of the first things one looks for on myeloproliferative disease. The sites of thrombosis are both in arteries and in veins, and we'll look at the reasons for that in a moment. And both clotting and bleeding may occur in the same person and even at the same time, which makes treatment rather complicated. Now, why is thrombosis and bleeding increased in myeloproliferative diseases? There are a number of reasons. First of all, platelets and neutrophils, which both contribute to blood clotting, may be enhanced in their functions, abnormally so. Blood clotting itself may be overactive in polycythemia because the high number of red cells increase the blood viscosity, as Dr. Silver has pointed out, and Dr. Spivak commented that lowering the hematocrit in polycythemia vera should be a mainstay of therapy. There is increased generation of thrombin within the blood itself, and there is decreased clearing up of clots, decreased fibrinolysis by a number of mechanisms, including changes in the way the blood vessel wall, the endothelium, responds to these stimuli. There's a shift in the endothelial function from non-reactive or antithrombotic functions, which are normally present at the level of where the blood touches the vessel wall, to prothrombotic surface properties, and there are many very distinct reasons for this. Indeed, the JAK2 mutation has recently been described in the endothelial cells of patients who have myeloproliferative diseases, as well as in the blood cells, and this itself may change the way the endothelium reacts. And all of these conspire together to make the blood move more slowly or to stop flowing. And I was taught as a medical student, when the blood stops flowing, it clots, and that remains true even today. Now, in polycythemia vera, as shown in the picture on this slide, of a small blood vessel clogged with too many red cells, high numbers of red cells can directly mechanically obstruct and slow down blood flow. The red cells pushing down through the middle of a vessel also press the platelets to the sides of the blood vessels, where they interact with the endothelial cells in a prothrombotic manner, making the endothelium more sticky and favoring the formation of clots. So purely mechanical factors can be important. Now, blood coagulation, which as a clotting person I always have to show, is a complicated process. And I want to demonstrate on this particular slide, that's not working, that injury or flow changes themselves can cause changes to the endothelium, which lead to platelet activation. Neutrophils, or white blood cells, can interact with the platelets in the same way. The endothelial damage can engender the initiation of blood clotting, and finally, in red, the clot forms. You can see that the platelets and the neutrophils and the endothelium, as well as the clotting factors in the plasma, all interact to favor excessive clotting. Now, thrombosis occurs in myeloproliferative diseases when high red cell numbers, high platelet numbers, or endothelial dysfunction, which may be related to those mechanical and chemical forces, engender stasis, which leads to too much blood clotting, and at the same time, the damage to the endothelium in particular can decrease the ability of the blood to remove clots that form, tilting the balance into the direction of thrombosis. So the disturbance of the vascular integrity by a number of different mechanisms can promote thrombosis or abnormal clotting. Now, when bleeding occurs in myeloproliferative diseases, there may be abnormalities in platelet function, and we'll see a little later, this usually occurs when the platelets are extremely high. And that leads to defects in blood clotting and sometimes to increases in the removal of clots that are actually required to mend injuries in the vessels, tilting the balance in the direction of bleeding. So again, a loss of vascular integrity can lead to bleeding in these diseases. Now, if this is a fibrin clot in glorious technicolor here, the green strands are the fibrin mesh, which is formed as the product of the coagulation of the liquid clotting factors in the blood. The fibrin mesh acts as a scaffold for a blood clot, either a normal clot or a thrombus. Platelets and a high hemoglobin in polycythemia vera with high blood viscosity, as you saw earlier, slows down the flow and favors the thrombosis. Platelets, the purple in this diagram, contribute to clot initiation. They act as a catalyst for the formation of blood clots, and they reinforce the firmness of blood clots by releasing a muscular sort of protein. So they also participate. And overactive platelets and white cells can favor thrombosis in polycythemia vera and essential thrombocythemia. Trapped red cells function mostly to give bulk to the blood clots. They don't have a great deal of catalytic function. And the abnormal vessel wall aids thrombosis, and as I mentioned before, can actually block the dissolution of clots. So the contributors, just to recap this, to thrombosis in myeloproliferative diseases include the activation of the endothelium and the shift in the properties of the vessel wall itself to favor clotting, the activation of platelets and all of their functions to favor clotting, the blood coagulation process itself with increase in the generation of thrombin, the key enzyme in clotting, and fibrin, the protein that you saw in the green strands in those last diagrams. And again, when the blood stops moving, it is going to clot rather quickly. Now, arterial and venous thrombosis are quite different and require different therapeutic approaches. Arterial thrombosis occurs in fast flow systems. Endothelial injury is the key to initiating these thrombi. Platelets can also initiate when they are activated, and disturbances in flow, as are common in the myeloproliferative diseases, can assist in this process. And the clots are called white clots because they're platelet initiated. And they actually tend to be small vessel, but not necessarily, and they actually are pale in color. And for arterial thrombosis, antiplatelet therapy is the mainstay. And we see arterial thrombosis a little more in ET than in polycythemia. On the other hand, venous thrombosis is more prevalent in a slow flow system like the veins. And here stasis is the key, the slowing down of blood flow. The formation of fibrin, the meshwork, is the central part. Platelets are less involved, but they are still involved to some degree. And these are red clots because they're very rich in red cells. And here, anticoagulant therapy is the mainstay. And here you see somewhat more venous thrombosis in polycythemia vera, as the very high red count, if it's not treated, can actually contribute strongly to high blood viscosity and low flow. Now, at diagnosis, thrombosis is often a presenting feature in myeloproliferative diseases. And here are some studies put together for large numbers of patients showing that in P. vera, at diagnosis, about a third of the patients present because of a thrombosis, a smaller number in ET. And that in both P. vera and ET, arterial thrombi, heart attacks, strokes, and so forth, are somewhat more common than venous thrombosis. But in polycythemia, venous thrombosis is present at a higher rate than in thrombocythemia. Now, these are all rare diseases, so there are very, very few properly conducted, large, randomized trials on how to treat anything. And there's a great deal of what's called expert opinion, which means we do not have clear-cut data, and never will have clear-cut data. And so experiential information has to be extrapolated as best one can. So when you put all the data together from all the trials that there actually have been published, the predictors of thrombosis in myeloproliferative diseases are age, but that's true of thrombosis in almost any setting. Prior thrombosis, which is also not exclusive to the myeloproliferative diseases, to some extent the JAK2 mutation burden, because that may or may not contribute to the aggressivity of the underlying disease, and to a great extent to the control of the disease, plus or minus antithrombotic therapy. And also, very important to take into consideration are what other factors are present that may favor thrombosis in an older patient, particularly acquired risk factors affecting a cardiovascular system, and inherited thrombophilias, which are much rarer but can certainly be present in patients who also have myeloproliferative disease. Now, how does the high JAK2 mutation burden affect thrombosis? It appears, and again, the data are rather limited, that if the JAK2 burden is high, the platelets are somewhat more immature and activated, and that usually means hyperfunctional, or at least dysfunctional. There are higher numbers of activated white cells, which are recently considered more and more to contribute to thrombosis in a great many settings, not exclusively myeloproliferative disease. And there are more red cell precursors that are capable of independent growth. And this also is correlated with more thrombosis. I've put some of the actual statistics that are available up there, but there's also a haplotype that is another kind of JAK2, not a mutation, but another allelic variation of JAK2, which appears to favor red cell production, whether or not the JAK2 mutation is present. And this also is an independent factor favoring thrombosis. Now, just to reiterate that the interaction between white cells and platelets and particles that are given off by both types of cells when they get together can also promote thrombosis. And there is now much more interest in looking in the liquid part of the blood for the presence of prothrombotic microparticles, which may add to the risk of any particular person having a thrombus at a particular time. Now, the treatment of the myeloproliferative disease does help to decrease the thrombotic risk. And the most important, I think, and this is particularly a favorite subject of Dr. Spivak, is that lowering the hematocrit into the normal range, which decreases blood viscosity and improves blood flow, is very important in decreasing the thrombotic risk. Lowering the platelet count by itself, by whatever means, may not decrease the thrombotic risk. And it is likely that one also needs to decrease the white cell count and the hematocrit as well in order to come back more to a normal hemostatic balance. Now, both hydroxyurea and interferon normalize the blood cell counts. They decrease those platelet leukocyte aggregates you saw in the last photograph. And they decrease somewhat the number of hyperactive and immature platelets. Hydroxyurea use has been shown to decrease tissue factor, which is another important component of the blood clotting system. And interferon, which is anti-inflammatory, preferentially decreases to some extent JAK2 positive clones, as I think Dr. Silver pointed out. Now, just in parenthesis, the use of aspirin relieves a very particular kind of complication in ET, and that is erythromelalgia, which is a very painful condition of the hands and feet usually, due to small platelet aggregates in the capillaries and very small arterioles. And aspirin is a very specific, by its antiplatelet action, ameliorator of that particular syndrome, which is not tremendously common. JAK2 inhibitor use to date has not been shown to decrease the thrombosis rate. Now, there have been a couple of studies to demonstrate that lowering the hematocrit, white cell count, and platelets decreases the risk of thrombotic events in polycythemia vera. This is from a recent paper in the New England Journal. You can see that this is for event-free survival, so that when you improve, the upper line is when you improve the blood count toward normal. The lower line, less event-free survival, is when the counts have not been corrected toward normal. The only study that has been done to date is the ECLAP study, published almost a decade ago in the New England Journal, that showed that low-dose aspirin does seem to decrease the thrombosis rate in polycythemia vera. And there are really no other studies to confirm this one at the present time. You notice that the bleeding rate on aspirin is considerably higher than the bleeding rate on the placebo, and that's an important point to remember as we go a little bit forward. The low-dose aspirin in this study was protective, that is, the risk rate is all to the left of the vertical line, showing decreased risk for duration of disease, cytoreductive drugs, yes or no, platelet counts, high or low, hematocrit, high or low. This is the best data that we have suggesting that low-dose aspirin is beneficial in decreasing thrombosis. Now, when should one use anticoagulation in polycythemia vera, where venous thrombosis is particularly a problem? If the hematocrit is not well controlled, if there is history of venous thrombosis, particularly intra-abdominal, splanchnic or portal vein thrombosis, if there is a persistent elevation of the white cell and platelet counts, if there are cardiovascular risk factors that are present in the patient, and if there's early myelofibrosis. Now, in essential thrombocythemia, depicted here with a normal blood smear on the left side and the very high platelet count, the arrow is pointing at a platelet, on the right side. What kind of therapy is needed to prevent thrombosis and bleeding? Well, that depends a bit on the risk classification for thrombosis in the essential thrombocythemia. So the risk factors I had put up before: age, history of thrombosis, cardiovascular risk factors, and JAK2 status. This is a score proposed by Dr. Barboui recently to correlate with how risky it is for a patient to have thrombosis. If the score is low, the risk is 1 thrombosis per patient year. If the score is very high, it more than triples. Again, no controlled studies here, too rare a disease. Very high platelet counts, as I mentioned before, promote bleeding. These are counts over 1.2 to 1.5 million. And the reason for this is mainly that the platelets soak up an essential clotting factor called von Willebrand factor and make it unavailable, resulting in bleeding, which is mostly in the skin, the mucosa, and the GI tract. And the largest forms of von Willebrand factor, which are the most important for hemostasis, are the ones that are most affected. This causes a disease called acquired von Willebrand's disease. Von Willebrand's disease is an inherited disease, usually, in which this particular clotting factor is either abnormal or low. If you lower the platelet count, the hemostasis can normalize again. Aspirin is helpful here also to decrease platelet hyperactivity. whereas the hydroxyurea and interferon, as you have heard earlier, will lower platelet production and improve platelet function to some extent. Now, I've talked this entire time without really mentioning therapy, even though that's the title of the talk. So let's talk a little bit about antithrombotic therapy in myeloproliferative diseases. In polycythemia vera, there is evidence that low-dose aspirin may be beneficial. There are differences of opinion on this point, and if the hematocrit can be kept normal by phlebotomy alone, and the patient has no cardiovascular risk factors, then it may be possible not to treat with anything. Otherwise, aspirin is used. If the patient has already had venous thrombosis, particularly in the abdominal cavity, or cerebral sinus thrombosis, for example, then Coumadin is the safest anticoagulant and probably should be used indefinitely because the risk of a recurrent thrombosis in a polycythemia vera patient who has already had one thrombus is quite elevated, up to maybe 20%, which is higher than in a person who doesn't have any myeloproliferative disorder. Again, there are no real studies on this. Should the newer anticoagulants, the new oral anticoagulants such as Xarelto, be used in this situation? There is absolutely no data on this point. The problem with using Xarelto or the similar agents which are now coming on the market is that there is no antidote and that they all have a certain risk of bleeding that is probably higher than the risk of bleeding from Coumadin. And therefore, it is probably not wise at this time to switch to these very convenient agents whose effects cannot be measured by any of the tests that we have and whose effects cannot be turned around by any of the antidotes that we have. So I think it's too early to consider that in polycythemia. Now, what about essential thrombocythemia? Low-dose aspirin is the traditional, whatever the platelet count, because the platelets do not function normally. In the young patient who has very few cardiovascular risk factors and a high platelet count, it may not be necessary to use aspirin. And there's always a certain amount of bleeding risk, even from low-dose aspirin. When I say aspirin in these disorders, I mean low-dose aspirin, which in the United States is 81 milligrams a day. In a few patients with essential thrombocythemia who have very rapid platelet turnover and a history of particularly microvascular clotting, it may be important to give the low-dose aspirin twice a day rather than once a day so that the platelets don't escape the use of the aspirin, as the drug is very rapidly cleared from the circulation. Curiously enough, in ET, the thrombosis risk does not really correlate well with the platelet count, even though we think it ought to. Only when the counts get very high does the risk of the acquired von Willebrand factor come into play. There are really no data available, and I looked very, very hard on the use of Plavix or the other newer ADP receptor inhibitors like FEN or Brilinta in the myeloproliferative diseases. There was supposed to be a clinical trial to start in 2009 with Plavix, and the company never released the drug for the trial, and it was closed before it ever opened again. It was an NIH trial. All of these newer agents may predispose to bleeding because they're powerful and very long-acting. And in fact, the newer, the prasugrel, ticagrelor agents in the cardiovascular setting do impose increased bleeding, and they're not being used as widely as people thought they would be. They're maybe too effective. So simpler is better. We need antithrombotic and antiplatelet agents in some settings of myeloproliferative disease, but at this time, we would do better, I think, to stick to the older ones, Coumadin and Aspirin, if indeed we need them, and to wait for more data before we move on to newer drugs. Thank you.